Hi guys, and welcome back to my channel. My name is Silibaziso Mupereki and I make content about everything to do with university life, nursing school and international student experiences. So if this would be the type of content that you'd be interested in, definitely don't forget to subscribe down below. So in this video, I'm going to be giving you an overview of my neonatal experiences. So as you can see, over the past couple of weeks, I've been doing, a lot of reviews about how my placements have been. So I've already done a video about my midwifery experience, which you can find over here. I've also done a video about my postnatal experience, which was last week's video. You can also find it on my channel, the clouds over there. And then today we're going to be dealing with my neonatal experience. So I've divided this video into three. The first part, I'm going to be telling you about the different neonatal units that we have in the hospital where I'm working. Then I'm going to be giving you a rundown of the general day that we have in the neonatal. The third thing is I'm going to be giving you some tips of how to take care of babies in the neonatal ward, and then just a few basic things that I learned that are very important. And I'm just going to have this notebook open because this is the book that I use in my clinical placement for just taking notes of things I need to remember, like PPH emergency protocols. And then I also written down about the neonatal units that we have and the type of babies that are categorized within those facilities, just for easy reference. So we have four main types of neonatal wards. So we've got the NICU, which is the neonatal intensive care unit. Then we've got high care one, which is high care. And then we've got the special care nursing unit. And then we've got the kangaroo mom care. So starting with the NICU, so babies that fall under this category is babies that were born outside of the hospital and are more than 1,000 grams, or babies that were born within that hospital but they are more than 800 grams and they must be more than 28 weeks. So they need a lot of interventions and being washed over and that sort of thing. And our NICU can only cater for 6 beds, so we can't be overcrowding babies because all these babies need a lot of attention, and if you've got a lot, things can go wrong and that sort of thing. And then the next thing is we've got high care. So sometimes babies that are in the NICU can move over to high care or vice versa. So in the high care, it's babies that are less than 1,000 grams and less than 28 weeks. Babies that are in the NICU, they require a lot more oxygenation and they require a lot more external help to breathe, whereas babies that are in high care, they don't need it as much, and most of them will usually be on nasal prongs. And they've got very minimal IV fluids. Most of them, they'll be just on Neonatal with some glucose, whereas in the NICU, they've got a whole glucose cocktail that happens there. So babies that are in the high care, they're not as critical and they're not on as many medications or interventions and that sort of thing, but it's almost like a step down to the NICU, if that makes sense, but they still need a lot of monitoring. So majority of the time we'll be checking your vital signs, so that's your pulse, respiration, temperature, and your saturation. And some babies will be on antibiotics or IV fluids and that sort of thing. So with those babies, almost every 3 hours we're checking their vital signs, and we're also doing feedings every 2 to 3 hours. So you're constantly busy doing something. As soon as you're finishing, you need to do your vital signs. As you're finishing vital signs, then you also need to be feeding again and that sort of thing. And some babies are still on NGD tubes, but they're able to breathe on their own, so they can be moved to high care. And then you've got special care nursing. For me, special care nursing, it's almost as if you're babysitting. Like, honestly, majority of the time we're changing nappies and we're feeding, because these babies that are no longer on oxygen, they're breathing well on room air, they're being established on cup feeding or being established on breastfeeding. Sometimes you have big babies that we're just monitoring to check their glucose levels, but it's pretty much premature babies that are really growing well on their own. They're not needing any external issues. Sometimes they'll be on like formula milk with added supplements, and they'll sometimes be getting multivitamins, but they don't need as much extensive monitoring of their vital signs compared to babies that are in high care and NICU. So majority of the babies in special care nursing, it's pretty much babysitting, and some of them will have their mothers staying either at KMC, which is the kangaroo mom care, or the moms will actually be staying in the ward, and the moms literally come every 2 to 3 hours to feed their babies, change them. So the moms will be doing majority of the stuff. We're just making sure that the mom knows how to feed the baby, counseling them, breastfeeding and all that jazz. And then there are some moms that are not staying in the hospital and they'll be at home. So those are the babies that we usually be feeding, comforting, bonding, home and that sort of thing. And then also in special care nursing, you have babies that are either up for adoption, or there's some social issues happening with the mom. Sometimes there'll be substance abuse, teenage pregnancy, and that sort of thing. So there's a lot more social issue babies in special care nursing, and they don't necessarily have to have something wrong with them, but they'll be there for us to take care of them while the social work and the doctors are busy trying to find a plan of what's going to happen with this baby. So that part of it can be quite emotional. Like, that was this gorgeous baby that was up for adoption. Anyway, that's just part of special care nursing. And then we've got kangaroo mom care. So kangaroo mom care is babies that are above 1.5 grams, 1,500 grams, and they're just in a normal ward, and the nurses are just there to help the moms establish good breastfeeding, because the baby will be growing well on their own, they're feeding fine, they're not on any monitoring. The baby is growing well, it's just that they're small and they're premature, and we just need to make sure that the mom has adequate information and they've been trained enough for them to be able to take care of that baby once they get home. And then once a baby reaches about 1,700, 800 grams, then they'll be allowed to go home with the mom. Pretty much these are the neonatal units that we have, and they all just fall under different categories. So for you how you fall under those different categories is depends on your weight, your gestational age, and the conditions that you have, whether you're on IV fluids, you need respiratory help, and that sort of thing. So I really hope you guys understand the different types of neonatal units that we have at my hospital. So now I'm just going to walk you through a typical day in the neonatal unit. I'm going to be covering the special care nursing and high care, because those are the only places that I've worked in. NICU was right next to high care, and I could walk in there and see what was happening, but I've never physically worked in there, so I can't really tell you what happens in there. And I haven't worked in KMC. I've just gone there with the moms to observe, and I was asking questions about what happens there, so I can't tell you how that part of it works. So I'm going to be telling you what happens in high care and special care nursing. I'm going to merge them into one, because I really don't want to be boring you with details of two things they're pretty much the same thing. The only difference is that in high care there's a lot more feeding, it's a lot more frequent. Like in high care you can have babies being fed 12 times a day, compared to special care nursing where you have a baby being fed 8 times a day. And then in high care, the frequency of the observations is a lot more than in special care nursing. In high care, we check the baby's vital signs at 7, at 10, at 12, at 3, and at 5. Whereas in special care nursing, we check the baby's vital signs at 7 and at 2, and then they'll check it again at 7, at 9. So those are the big differences, but everything else is pretty much the same thing. So a typical day starts usually 20 past 6:30. So this is when the night staff is giving handover or communicating the information of what happened to the babies during the night to the day shift. So if there were any issues during the night, or if any medications was changed, because sometimes babies can be started or changed on medication during the night, and that needs to be communicated to the day staff. Or if the night staff had some issues with the babies, or medications was prescribed wrong during the day and then that caused difficulties in the night, that needs to be communicated to the day staff, because during the night there aren't as many doctors walking around and doing rounds. So as a result, most of the things can only be fixed in the morning. Emergency staff, they would call the on-call doctor, but if it's not an emergency and something that can be sorted out in the morning, then obviously that needs to be communicated. But it's just the general handover of continuity of care. From 7 to 7:15, it depends how many babies that we have in the ward. So during handover, you're writing what's the baby's condition that you found them in. Are they alive? Are they dead? Are they active? Are they lethargic? Is they breathing well? What is the skin, the outlook of the baby, the skin color? Is it well perfused? Is there pink? Is there any signs of cyanosis? Is their skin intact, especially the buttocks, changing nappies and that sort of thing. And also because most of these babies are quite premature, and if you're constantly holding them and rubbing them, their skin can break down quite easily. So we need to be monitoring that. And then also we need to check if they have IV lines, is there any perforation or tissuing of the skin and that sort of thing. So the general condition of the baby, are they laying in an incubator, are they on room air, oxygen, and that sort of thing. So all those things need to be communicated, so that in case something happens to this baby, we need to know, did it happen during the night or did it happen during the day? So that's why you need to make an accurate and honest examination of that baby, and you need to make sure that you're as detailed as possible when you're making that interim. And then after that, we start preparing the medication for the babies and their feeds. So by 8 o'clock, we'll be feeding the babies, we'll be changing nappies. Then after that, we need to clean the incubators. So cleaning of the incubators, or just the general area where the babies are, it happens frequently during the day, because babies, especially premature babies, they're very highly susceptible to infections, illnesses, bacteria, and that sort of thing, especially now with COVID and having different doctors coming in and out, moms coming in and out. We need to make sure that we're constantly washing our hands and we're constantly having to disinfect services, things that we give to the baby, like your thermometers, your vital sign machines, and that sort of thing. So all of that has to be cleaned. But yeah, after the handover, we feed the babies, they get their medication mixed into the milk. That's the easiest way to do it. Then after that, we do the vital signs, where we're taking the pulse, the respiration, temperature, and SADS monitoring. And you need to make sure that you know your vital signs, especially the baby. It's very nitpicky. I'll put the vital signs of a year for your own information, but it's very important that you know the vital signs, because should anything be wrong in the baby, especially the temperatures fluctuate a lot. Because if the temperature is too high, you need to make sure that you're removing blankets, and sometimes the incubator can be set at a very high temperature and you need to lower it, or vice versa. So you need to know your vital signs so that you can provide intervention quickly, because with the baby, their conditions changes rapidly compared to adults, where you can take a couple hours and that sort of thing. So please make sure that you know your vital signs. Then from 9 o'clock, the first tea will go at 9 to 9:30, second tea 9:30 to 10. This was very different compared to postnatal, because at postnatal our tea was from 9 to 10 was first tea, and then 10 to 11 was second tea. So that was a big adjustment. But anyway, so during 9 and 10, the doctors will be doing their rounds, they'll be writing orders, and then we need to go through the files, see what the doctor wrote, and then we need to put those interventions into practice. So if the mom is being discharged, we need to make sure, if they are not in the hospital, they need to be called so they come in to fetch their babies, and they need to get the immunizations before discharge, because we don't give immunizations while they're still sick, because sometimes the medication can actually increase their temperature or make it spike if you're sick and that sort of thing. So we wait until they're about to be discharged before we give them the immunizations. So that needs to happen. There's a lot of paperwork that happens. Sometimes babies are being moved through the different neonatal units. So if you're in NICU, you end up in high-care. If you're in high-care, you end up in special care nursing. If you're in special care nursing, you might move to KMC, and then KMC hopefully to home. Or sometimes you will have babies that are in special care nursing but their moms are not in the hospital, and sometimes we need to organize a lodger permit for the moms to come in to sleep in the ward, so they're able to interact with their mom, to make sure that we're establishing breastfeeding, counseling, and that sort of thing. Sometimes there's social work referrals that need to happen, transfers between the neonatal wards, so that can become pretty busy. But if we have very few babies, it's pretty quiet. And then from 10, 11, and 12, it's not as busy. Pretty much at 10 we're doing feeds again, and then at 12 we're doing feeds again, and then continuing to carry out the different doctor's orders that we have. And if we have very few, pretty much we'll be just sitting and watching over these babies, and the moms from KMC and the moms that are lodging in the ward will come in, playing with the baby. The majority of the time we'll just be sitting and talking. Sometimes you're reading through the files to see why the baby ended up in high care or special nursing care, and that sort of thing. And then from 12 till 1 it's first lunch, 1 till 2 is second lunch, and during that time at 12 we will be doing the second feed. We'll be doing the feeds again. At 2 we'll be doing the feeds again, and then also around 1:30 to 2:30 we'll also be doing vital signs, changing nappies, cleaning all over again. So there's a lot of feeding that happens. So we feed at 8, we feed at 10, we feed at 12, we feed at 2, sometimes we feed at 3 if we've got 3-hour babies. So we've got 2 hourly babies, and then we've got 3 hourly babies. So there's babies that feed every 2 hours, so that would be 8, 10, 12, 2, 4, 6. Then you've got 3 hourly babies where they get fed around something to 9, so it will be 9, 12, 15, 18. and sometimes there are times interchange. It's a lot of a lot of feeding and trying to balance all of that jazz. And sometimes we try to have all the feeds happen at the same time, so you need to balance out so that it's not too late, it's not too early. And sometimes you need to make sure that you don't do it too late, or the babies will start crying and all that jazz. Sometimes babies will also be started on phototherapy to help with a condition called jaundice. So all of that needs to happen. And then at 3 we also have feeds again, and then at 4 we need to do the last interim, so how the baby was during the day, if any medication was changed. So you need to give a report to the night staff that's coming in. If you're in high care, then at 5 you'd also do vital signs, but in special care nursing we don't. We do the writings at 4, then we feed them at 5, and we're pretty much sitting until the end of the shift. So that's a general overview of how it is in the special care nursing and high care nursing. They pretty much happen in the same way. So what things have I learned in the neonatal and high care units? One, babies are very specific. Like when you're feeding babies, you don't just pour what you think is enough, or you feed the baby until they're full. They've got specific calculated amounts of feeds that they get. Like we've got specific babies that are getting 16 mils of baby formula, and then some babies they had 66, 54. So you've got very specific numbers that you need to measure out, and especially also with medication and that sort of thing. So babies are very specific when it comes to their feeds, their medication, and their vital signs. So it's very important that you taking note of that. The other things I've already mentioned them, but infection control is very important. Wash your hands, clean the incubators, the cots, and all of that. Vital signs, you need to know your normal ranges. It's very important that you do. Third thing, minimal handling of the babies. They're very frail, like they're very tiny, and you can see all their skeletal muscles, you can see all their bones and that sort of thing. So please make sure that you're protecting those babies. Don't put them on hard surfaces, don't rub them and that sort of thing, because their skin breaks down very easily. So we don't do dummies and we do not do bottles. Everything happens via a cup. It's the best way for the baby to suck. Guys, I thought I knew how to feed a baby until they introduced me to the cup, because I was so used to feeding a baby with a bottle, but a cup is much better. It's been scientifically proven and all of that jazz. The first time I fed a baby, like I had so much milk spilled everywhere, because there's some very aggressive babies, like they'll be sucking like so much milk, but because you are pouring into the mouth, sometimes they suck too much and they start coughing, that goes everywhere. It's definitely a skill that you need to learn before you even touch a baby. Like, anyway, but it's definitely something you need to learn how to do, because it can go very messy very quickly. The moms require a lot of breastfeeding counseling, because for some moms, breastfeeding comes naturally, like as soon as they have the baby. And especially moms that have got very protruding nipples, it becomes so much easier for them to feed, because the nipple literally just goes right through into the mouth. But some, they have difficulty of the milk actually coming out and being produced. Some have way too much milk and it needs to be expressed and stored properly. So there's a lot of feeding counseling that you need to do, whether the mom is struggling with breastfeeding and they need to know how to express. You need to teach the mom how to express the milk, and then you also need to teach them how to store it when they get home, because most of them, they will start going back to work, so they need to know how to do that, how long milk can stay in the fridge, how long it can stay in room temperature, how long you can freeze it, and all that jazz. So you need to know all of those things, and you need to counsel your moms about that. And the last thing is you need to provide your moms with a lot of health education. Most of these moms, they're very stressed. Some babies stay in the hospital for 2 to 3 months because of complications. The baby's not growing well, they get an infection and that sort of thing. So most of the time they'll be very anxious. They'll be wondering why certain things are happening. And like in any ward or with any patient in the hospital, please make sure that your patients know what is happening with their care. I don't know, there's just this culture in nursing where there's communication between the doctor and the nurse, but nothing ever goes to the patient. And especially with moms, they get very stressed because they hear a lot of chatter but they're not being told what is happening. So it's very important that we're telling our moms what is happening, why certain procedures are being done, why certain investigations must be done, why we ask mom to wash their hands because they just come in and they want to hold their baby. So make sure that everything that you're telling your moms, you're explaining the why so they understand and why it's the best for the baby. So overall, this was my experience in the neonatal ward. It's definitely such a cute profession or cute ward to be in. Like, the babies are so gorgeous and they're so tiny. Oh, they're so precious. And there's some really cute babies. Would I ever work in a neonatal ward? No. I don't know. I didn't like it. I felt like it was a lot of babysitting. There's a lot of things that definitely you learn. Like, there was a lot of reading up that I had to do regarding babies because I was so used to dealing with adults. So that was a good refresher to know, to learn about vital signs for babies because you're so used to how adults are. And there's a lot of procedures that happen. There's a lot of values that you need to know, like your blood gases, your AGTs, your phototherapy, and all that other jazz. But so that was definitely intellectually stimulating and it was fun to do, but it's just way too slow for me. It's too slow pace. It's just a lot of babysitting, and I enjoy it. I love babies, but I feel like midwifery and the labor part of it really caught my attention, and I was introduced to that first, so I had the whole kick and the whole adrenaline from that everything else is just not, it's not hitting the right spot as labor does. So for me, at this moment in time, labor is it for me. I love labor and I definitely want to work in labor and perhaps antenatal. I do enjoy antenatal part of it, but definitely labor is where all the action is. So if you enjoy dealing with babies and you enjoy being intellectually challenged, because with babies there's a lot of things that are happening in investigations and you need to know why those things are happening because they will help in your nursing care plan. If you enjoy that, you would definitely enjoy neonates. This is just me giving you the experience, what you can expect, but it's just not for me, unfortunately, or fortunately. I don't know, I guess it's opening up spaces to more people because they are also quite short-staffed, and me being the only student working there, I literally had to jump around between high care and special nursing care. So in one day I could work in both because they were short-staffed and that sort of thing. So I guess they do need people there, but it's just not it for me. But I hope you guys enjoyed this video, you learned something from it, and I'm hoping I'm opening your eyes to the different wards and different specialities that you have within nursing. So until next week, Friday, 12 p.m. South African time, have an awesome day. Bye, guys.